This topic is about Hirschsprung disease. Hirschsprung disease is a congenital condition, and essentially what it is the bowel is unable to pass stool effectively. In Hirschsprung disease, the bowel does not contain certain nerve cells or ganglionic cells that help the bowel to relax, contract, and create that peristalsis motion in order to pass the stool. So in these infants with Hirschsprung disease, you can see the distal end of their bowel, or the colon, is extremely tightened and that sphincter is not able to relax. This can cause risk for perforation or even an infection in the colon. As you can see in this diagram, the infant's bowel towards the middle of the bowel is dilated and distended, but towards the end of the bowel, or the distal end, you can see that it's more narrow. Due to this inability of the distal bowel to be able to create peristalsis, pass stool, and relax, this can cause buildup of feces and an obstruction. So what are we going to find on our clinical assessment of a child with Hirschsprung disease? Well, there's an obstruction in the bowel, so the bowel has to accommodate for that, so it will become distended and enlarged. The child may experience feeding intolerance due to the bowel not having enough room to tolerate the formula or food. Bilious vomiting is another clinical feature that's classic for Hirschsprung disease, and this is due to the obstruction being below the duodenum, so the bile is able to make its way back up. Ribbon-like stools can also occur due to the narrowing and the contraction of that distal colon, and this can change the presentation of the stools into a thin ribbon as it passes through that narrow lumen. This can then also lead to decreased weight gain and growth development delays. Typically, infants with a healthy bowel will pass meconium, or their first stool, in the first 24 hours. So it becomes concerning when the infant has not passed meconium by the 48-hour mark, and that's when we want to monitor for Hirschsprung disease. We can diagnose Hirschsprung disease by a barium enema or a rectal biopsy. The rectal biopsy will show on that non-functional portion of the distal bowel a lack of those nerve cells or those ganglionic cells. So as depicted in this diagram, you'll see the dilation and distension of that intestine towards the upward portion of the blockage or the obstruction, and towards the bottom of the distal end, you see that narrowing yet again, which is classic presentation for Hirschsprung disease. So how do we treat clients with Hirschsprung disease? Surgical intervention is the only way to resolve this issue. Checking serial abdominal girth or distension is extremely important, and if we notice an increase in the measure of that abdominal girth, we want to make sure we're notifying the healthcare provider. We want to make sure we're preparing our clients for surgery. During this surgery, the surgeon will remove the non-functional portion of the bowel. So to prepare our clients for surgery, we want to make sure that we're implementing NPO precautions. This is to allow the bowel to rest, as well as to decrease the risk of aspiration during surgery. Administering IV fluids is important to keep our clients hydrated. It's important to note that most clients with Hirschsprung disease may be younger in infancy, but some children may discover this Hirschsprung disease later in life. In this case of Hirschsprung disease in an older child, they may require a clean out or an enema before going into surgery. After surgery, we want to make sure we're monitoring for infection. That's always our #1 priority. So we want to make sure that if we see any increased redness, swelling, tenderness, a fever, or even discharge from the incision site, that's concern for an infection, and we want to notify our healthcare provider. Now, depending on how much of the bowel was affected and non-functional, the surgeon may have to remove a large piece of the bowel, which would indicate a placement of a colostomy. With a colostomy placement, we want to make sure we're educating clients and families on how to care for the stoma. The stoma should always be moist and red in presentation. The client should be assessing their stoma regularly, and if they note any discoloration or dryness or even discharge, they need to notify their healthcare provider.